Welcome to Roadmap to Residency. In this video, we are covering respiratory infections in children for the Step 2 Clinical Knowledge exam. This is one of the most commonly tested pediatric topics on the boards, and today we are focusing entirely on test-taking strategy. We are not going to reteach the material from scratch. Instead, we will walk through the high-yield question stems you will actually see on exam day and give you proven strategies to get the right answer quickly. Make sure you have already reviewed the pediatrics and infectious disease chapters in your primary study resources and question bank before watching this video. This video is about applying what you already know. Let us get started. Here is what we will cover today. First, we will learn to recognize the classic question stems the boards use for croup, bronchiolitis, pneumonia, and other pediatric respiratory infections. Second, we will apply specific test-taking strategies for strep pharyngitis, Pertussis, otitis media, and sinusitis. Third, we will master the next best step question format that the exam loves to use for diagnosis and management of these conditions. Before we dive in, make sure you have reviewed your pediatrics and infectious disease chapters in first aid, your preferred question bank, and pathoma. This video is about applying that foundational knowledge on exam day, not learning it for the first time. Our first strategy is the age-based approach. The boards love to test respiratory infections in children, and the single most important clue they give you is the age of the patient. When you see an infant under 2 years old with wheezing, tachypnea, and nasal flaring, your mind should immediately go to bronchiolitis caused by respiratory syncytial virus. If the infant is a neonate under 60 days with fever, remember that the boards want a full sepsis workup, regardless of how well the baby looks. Now, for toddlers and older children, the clues shift. A barky cough with inspiratory stridor in a child between 6 months and 3 years old is the classic croup presentation. A school-age child with productive cough, high fever, and a lobar consolidation on imaging is bacterial pneumonia. Always let the age of the patient guide your first step in answering the question. Strategy 2 is the barky cough versus wheeze split. This is one of the most reliable shortcuts on the exam. When the question stem describes inspiratory stridor with a barky seal-like cough, you are looking at upper airway obstruction. This is croup until proven otherwise. If the board question shows you a neck X-ray, look for the steeple sign which confirms subglottic narrowing. Now, there is one critical exception. If the child is drooling, looks toxic, has a high fever, and is refusing to swallow, that is epiglottitis, and you should never examine the throat. On the other side, expiratory wheezing with tachypnea and intercostal retractions points to the lower airways. In an infant, this is bronchiolitis. In an older child with recurrent episodes, think asthma. Diffuse bilateral crackles with fever in any age group should make you think pneumonia. The boards test this upper versus lower airway distinction constantly. Now let us talk about recognizing the classic question stems. For croup, the boards will describe a toddler, usually between 6 months and 3 years, who has a barky cough, a low-grade fever, and inspiratory stridor that gets worse at night. If they show you an X-ray, look for the steeple sign. Treatment is a single dose of dexamethasone, and you add nebulized epinephrine if the case is severe. For bronchiolitis, expect an infant under 2 years who starts with a runny nose and then develops wheezing, rapid breathing, and trouble feeding. The cause is almost always respiratory syncytial virus. Management is supportive care with nasal suctioning and hydration. The boards love to test that antibiotics are not indicated here. For pertussis, the classic stem describes paroxysmal coughing fits followed by an inspiratory whoop or vomiting after coughing. There may be a history of an initial cold-like phase. The test to confirm is a polymerase chain reaction nasopharyngeal swab, and treatment is a macrolide antibiotic like azithromycin. Let us work through our first practice question together. A 2-year-old boy is brought to the emergency department in the middle of the night with a harsh, barky cough and noisy breathing. His mother says he had a runny nose and low-grade fever for 2 days before this started. On exam, he has inspiratory stridor at rest, mild intercostal retractions, and his oxygen saturation is 94%. The question asks for the most appropriate initial management. Take a moment and think about what diagnosis this question is describing and what the right answer would be. We will walk through the answer on the next slide. Here is the answer walkthrough. Step 1, spot the pattern. We have a toddler with a barky cough, inspiratory stridor at rest, a low-grade fever, and it all started with upper respiratory symptoms. This is textbook croup, also called laryngotracheobronchitis. The nighttime worsening is a classic clue the boards love to include. Step 2. Gauge the severity. This child has stridor at rest with intercostal retractions. That tells you this is moderate to severe croup. Mild croup only causes stridor when the child is agitated. When you see stridor at rest, the child needs both nebulized racemic epinephrine for rapid short-term relief and dexamethasone for sustained improvement over the next day or two. Step 3. Eliminate the wrong answers. Option A, oral amoxicillin, is wrong because croup is a viral illness and antibiotics have no role. Option B, nebulized albuterol, treats lower airway bronchospasm in asthma, not upper airway edema. Option D, intubation with intravenous antibiotics, is far too aggressive for a child who is maintaining adequate oxygen saturation. The correct answer is C, nebulized racemic epinephrine and dexamethasone. Here is our next practice question. A 6-month-old infant is brought in during the winter with 3 days of nasal congestion and cough that has now progressed to wheezing and difficulty feeding. On exam, the infant has diffuse bilateral wheezing, subcostal retractions, a respiratory rate of 56, and oxygen saturation of 91% on room air. The question asks for the most appropriate next step in management. Think carefully about the age, the season, the symptom progression, and what the evidence says about treating this condition. We will break it down on the next slide. Let us walk through this answer. First, spot the classic clues. We have an infant under 12 months old, it is wintertime, and the illness started as nasal congestion before progressing to wheezing and difficulty feeding. This is textbook bronchiolitis caused by respiratory syncytial virus. The age and seasonal pattern are the strongest diagnostic clues on the boards. Do not get distracted by the wheezing and think asthma. Infants this young do not get diagnosed with asthma. Now, why does supportive care win? This is one of the highest yield board concepts in pediatrics. Multiple studies have shown that albuterol, corticosteroids, and antibiotics are all ineffective for bronchiolitis. The boards will try to trick you with these options. This infant has an oxygen saturation below 92%, so supplemental oxygen is the priority along with nasal suctioning to maintain the airway and help with feeding. The correct answer is C, supplemental oxygen and nasal suctioning. Remember, on the boards, less is more when it comes to bronchiolitis management. Now let us cover 2 more high-yield conditions for the boards. For strep pharyngitis, the boards love to test the Centaur criteria. Those are fever, tonsillar exudates, tender anterior cervical lymphadenopathy, and the absence of cough. When you see 3 or more of these criteria met in a question stem, the next step is to confirm with a rapid strep antigen detection test. First-line treatment is oral penicillin or amoxicillin. A critical board pearl is that you should never treat strep throat based on clinical criteria alone without testing first. For acute otitis media, the key board concept is knowing when to treat immediately versus when to use watchful waiting. Children over 2 years old with mild unilateral symptoms can safely be observed for 48 to 72 hours. However, children under 2 years old, those with bilateral ear infections, or those with severe symptoms like high fever or severe ear pain, need immediate treatment with high-dose amoxicillin. The most specific physical exam finding the boards test is a bulging tympanic membrane. Here is another practice question. A 7-year-old boy is brought in with 3 weeks of cough. The illness started with a runny nose and mild fever that went away after 1 week. Now he has severe coughing fits that cause him to turn red, followed by a forced inspiration. He sometimes vomits after coughing episodes. His vaccination records show he missed his childhood boosters. The question asks for the most appropriate next step. Pay close attention to the timeline, the cough characteristics, and the vaccination history. Think about what condition this is describing and what the best next step would be. We will walk through the answer next. Let us break down this answer. The classic pattern here is a 3-week cough with distinct phases. The catarrhal phase comes first with cold-like symptoms. Then comes the paroxysmal phase with severe coughing fits, forced inspirations, which is the whoop, and post-tussive vomiting. Incomplete vaccination history is the critical risk factor the boards include to guide your diagnosis. This is textbook pertussis, also known as whooping cough. Now let us eliminate the wrong answers. Option A, chest X-ray and amoxicillin, is wrong because this clinical picture is not bacterial pneumonia. Amoxicillin would not treat pertussis. Option C, rapid strep antigen test, is wrong because strep pharyngitis causes sore throat, not prolonged cough with this specific pattern. Option D, supportive care only, is wrong because untreated pertussis is highly contagious. Treatment with a macrolide antibiotic limits the spread to close contacts and is required. The correct answer is B. A nasopharyngeal polymerase chain reaction swab confirms the diagnosis, and azithromycin is the first-line treatment for pertussis. Here is a critical test-taking pearl about sinusitis and when to order imaging. For sinusitis, the boards will describe a child with nasal congestion and purulent drainage lasting more than 10 days without any improvement, or symptoms that seem to get better and then got worse again. This is called double worsening. Facial pain and fever may or may not be present. First-line treatment is amoxicillin clavulinate. A very important board pearl is that routine imaging is not needed for uncomplicated acute sinusitis. Now, knowing when to image is tested frequently. You should order a chest X-ray when you suspect pneumonia. For Croup, an anteroposterior neck film showing the steeple sign is a classic finding, but imaging is not required to make the diagnosis clinically. The biggest trap on the boards is ordering sinus imaging for straightforward sinusitis. Only order imaging when you suspect a complication like orbital cellulitis or intracranial extension of infection. When in doubt on the boards, remember that less imaging is usually the right answer for uncomplicated pediatric respiratory infections. That wraps up our test-taking strategies for respiratory infections in children. Let us quickly recap what you should take away from this video. Always use the age of the patient as your first diagnostic clue. Remember the barky cough versus wheeze split to distinguish upper from lower airway disease. Know that bronchiolitis management is supportive and the boards will try to trick you with unnecessary treatments. For strep pharyngitis, always confirm before you treat. For pertussis, recognize the 3 phases and the incomplete vaccination history. And for sinusitis, remember that imaging is only needed when complications are suspected. For your next steps, review the pediatrics and infectious disease chapters in first aid and your preferred question bank. Practice as many questions as you can on this topic. Visit roadmap2residency.com for expert tutors and residency advisors who can help you build a personalized study plan. If this video helped you, please like and subscribe so we can keep making high-yield board review content for you. Good luck on your exam, and we will see you in the next video.